communication with patients, I would say, is the biggest source of patient disquiet or complaint. I would like a system whereby I can just go online, click, boom, there's my appointment there, it's booked, clicked, it's done. You don't need to have some back and forth, 20 emails to figure out when I'm free, when is the consultant available. I just want to see it on a screen, see what's available, click, book, done. I think that if the operational side of it is working very well, I think it reflects well on the clinician and the expected and the likely level of clinical care that's going to be delivered. If that email doesn't reach me for 2-3 weeks, that patient has now had a very bad experience, feeling like you're welcomed, feeling like you're looked after, feeling like somebody actually cares. There's lots of different ways to do that, but delivering that sensation or that emotional feeling that somebody actually cares about you as a patient, I think is important.
Welcome.
Thank you very much for having me.
Yeah, pleasure. Would you mind introducing yourself? Tell us a bit about who you are, your
Sure.
background.
Yes, so I'm Krista Farrell. I am a member of the Medical Advisory Board here at Coherent. I'm a consultant neurologist and the clinical lead for neurology in West Hearts. I'm also based in that hospital neurology and neurosurgery, and I do private work. I've also got a broadening interest in health tech in general, so I've been involved with the ambient voice technology rollout in our trust as well.
Of hats.
It's a lot. Yes.
I, despite working in healthcare, would be very curious to understand what a day in the life of a neurologist looks like. I think a lot of people probably don't know what a day in the life of a neurologist looks like. So can you just, if we followed you around with a camera all day,
Yeah.
what would we see?
How does it? Okay, so neurologists are physicians. I think most people probably don't know necessarily the distinction, but physicians are doctors who see patients and treat patients with medications. We don't do operations. And the kinds of problems we treat in neurology, things like dementia, epilepsy, headache, those multiple sclerosis, that's our bread and butter, as we call it, of conditions that we see. So a typical day would be outpatient based. So we see patients that are not staying in the hospital. People are coming for their appointments from home. So usually I turn up to work, I get into my clinic, log on to the computer, have a read of the referral letters that have been sent about the patients to see what is the problem or what the hypothesis of what the problem is, get a synopsis, and then call the patient in. And I would say that in terms of neurology, we spend a lot of time with patients asking questions. So taking a history is the term we use for that in medicine. So lots of questions about what problems they're having and how those problems affect them. And the purpose of that from a sort of medical point of view is to try and work out where in the nervous system the problem might be. And then that then hones in on what I might be looking for when I do the examination. So we then examine the patient, which is usually a fairly thorough top to toe assessment, because obviously your brain controls your whole body. So we do quite a lot. And then a conversation with the patient, sort of synthesizing my thoughts about what I think the problem is and therefore how we're going to approach managing it. Once that is then communicated and the plan is made, then there's the sort of 10 minutes or so worth of admin that comes after that, which involves producing a clinic letter for the patient, various methods of doing that. That's the communicating with the patient's GP to let them know what we've discussed and planned, and also communicating with the patient to let them know what we discussed and planned, and requesting lots of tests, investigations, etc., typically if those are needed, before follow-up appointments if those are needed, and then off they go, and then that wheel just turns itself several times over the course of the day with a little snack or break in between.
Got it. I actually didn't, the classification of physician
and surgeons, yes.
You do neurology, you just didn't.
So people often think, oh, you assume they're a neurosurgeon. No. So I always tell people, it's like House. If you watch House, that's a physician. It's somebody who spends a lot of time thinking about what's wrong with the person and then treating them, but without a knife to skin. Yes.
Okay, got it. So my head goes a few places. The first one is, it sounds like a lot of things need to go right for your day to go as planned. Things that need to go right. The cake.
That definitely.
In the morning. Very important. The cake in the morning. But in all seriousness, the patient arriving on time, the patient leaving on time, the next patient arriving on time, the note-taking that happens after, the referral letters going to the right place. There are a lot of moving parts around what you do. How does that get done?
There, behind the scenes of the clinician's practice, there was a whole team of administrators and lots of different labels, patient pathway navigators, medical secretaries, lots of different labels of people who are involved in the actual booking process, uploading of the referrals. Usually those are sent like as a PDF from whether it's in the private sector or public sector, it doesn't particularly matter. That has to be put onto the HR, the appointment has to be generated. So there's a massive operational element that surrounds the running of any clinic that is happening.
So it's interesting. I think when people think about healthcare, they often think about the conversation they have with you, what's happening behind the scenes. The patient doesn't necessarily know what's happening behind the scenes. So you're, I guess, the interface in some ways in all of this stuff that needs to happen in order for the patient to be served and for you to address their clinical needs, but also in some ways providing that point of assurance, that guidance yourself on the healthcare pathway.
Absolutely. I would say that a medical secretary is, if you have a really good one, great ones. I have a great one now. I've had a fantastic one before. I've been fortunate to work with excellent people, but having great people working with you on the administrative side, I think is integral to be able to deliver a decent standard of care. That those processes working properly and smoothly are a hugely important part of delivering a reasonable standard of care.
As a practitioner, you just use the words delivering a reasonable standard of care. I'm curious, if I'm controversial for a minute, where do you see the boundaries of a reasonable standard of care? What fits inside of that? It's a big question.
Well, that's a tough question. I guess I should say a good or high standard of care. But what that would mean is that patients need to have access. I can talk from the perspective of a patient as well as being a doctor, because pretty much every doctor's been a patient at some point, what it's like to be on the other side of the experience as well. But you're trying to book an appointment, you send off some inquiry, for example, you're waiting, you don't know it's just lost somewhere. Has anybody seen it? Has somebody seen it? Has not been action? Has somebody tried to get in touch with you? You don't know what's happening. Being able to access the person that you want to see or trying to see or sometimes have already seen but then can't get in touch with is really important. At the start of the patient journey, certainly knowing whether or not the person you might be booking an appointment with is appropriate for the problem that you think you have, for example, that you get a sense that their operations are running in such a way that you feel is aligned with your particular goals for how you would wish your healthcare to be delivered and managed. And I do think that is an important part. I think that if the operational side of it is working very well, I think it reflects well on the clinician and the expected and the likely level of clinical care that's going to be delivered, to be honest. And then after you've already had the consultation in terms of getting the documents, after knowing what's going to happen, any follow-up tests and things like that you need to book and sort out, knowing what the process is going to be, understanding that, and therefore optimizing that in such a way so that people can actually get what they need at the time that they need in a timely fashion so that you can then do your job to the best of your ability.
So in the box of a good standard of care, great standard of care, some of that box is filled up with patient access, operations, support, etc. Some of that box is filled up with clinical care, actual addressing of the clinical concern, whatever that concern may be. You are a senior practitioner. You are involved with different parts of the ecosystem. You practice privately. You practice with trust. Do you feel like those two halves of the box, operational access, support to the patient, and clinical care, do you feel like they get the same amount of attention where you work?
I think the National Health Service is a very different situation and they have very different demands. But there you have a situation whereby the demand, it far exceeds the actual capacity. In a private setting, that isn't quite the case, and you've got different, I won't say different priorities, but they are different pressures, I suppose is the best way to put it. So if I think about in the private setting, which is, I think, most relevant to a company like Coherent, certainly from the perspective of the patient, would I say they get the same amount of attention? My impression is possibly not. I think fundamentally, a lot of UK private practices of actual medicine as such, people coming with a disease or problem that needs to be addressed, that care. There's practitioners, clinicians like myself who are operating on their own, and therefore you're medically trained. That's your thinking, and your priority, your overarching priority, as it should be, is your delivery of the healthcare to the patient. And then these are other elements that are part of that process. However, So yes, the spotlight is on the interaction between the doctor and the patient and what we are actually doing. But I do think that there is reasonable focus on the admin and operational wraparound, but probably not as much emphasis that there probably should be to ensure that patients have a better experience overall.
That's very honest of you. I think the words patient experience are these big words. They're very big words. And there are entire software platforms built on patient experience. There are entire teams at private hospitals or elsewhere that are patient experience teams. There are chief patient experience officers. There is a growing, and there has been for a while, movement of trying to deliver that experience. And I think one of the questions I have is, you've been in practice now for a while. How have you seen patient experience change over the last 5, 6, 7, 8, 9 years? What's different from a patient perspective? What are the expectations? Right. And similarly, from a provider perspective, have they being the provider, have they reprioritized patient experience? Have they thought differently about what they want to deliver? What is the conversation about patient experience today versus the conversation 5 years ago, 10 years ago?
10 years ago. And certainly now there's a big emphasis on these platforms that you use to have star ratings, for example, where patients will go online, for example, and say, give their 5 stars or 4 stars or how many ever stars may be appropriate following consultation. That applies to both hospitals and to individual clinicians, departments, where they may have had their care. I think there are mixed views about that, certainly from the clinical side, because clinician-patient interactions are, by their very nature, complicated. And it's not necessarily a case that if somebody is dissatisfied with the experience, it doesn't necessarily mean that somebody has done anything wrong or bad. Sometimes we do have to have difficult conversations. Sometimes the consultation doesn't go well, and that's just the nature of the beast that we are dealing with. Not every intervention we make is going to go perfectly. People can have complications. There can be problems. But that said, from my experience, certainly as a head of department, I can say, particularly in a specialty like neurology, where you don't have surgical interventions, where complications, for example, are a big part of probably what they spend a lot of time managing. But communication with patients, for example, I would say is the biggest source of patient disquiet or complaint. So being able to access, being able to get their letters, knowing what the outcome of their test was, they haven't heard. And it's usually because some scan, the result hasn't come at an appropriate time, or something has been missed somewhere along in that route between the patient being seen. And time has elapsed and this person obviously has long gone out of the mind of whoever has seen them, simply because we see hundreds of thousands of people a year. All of that has come together to mean that effectively communicating with patients, ensuring that our interactions are appropriate, ensuring that the letters we send out are timely, the appointment information is clear, people know where they need to go, they've got directions to what they need. Like you said, whole departments dedicated to patient experience, different names for these things in different places, as you pointed out, have emerged out of all of that. But are we still doing it as well as we could? I think there are lots of things that could be made quite a lot slicker and a lot easier, that will optimize things, I think, for a significant proportion of people who are coming to seek care.
I put £1 million in your hand, and you can spend that £1 million solving one problem inside of patient experience. One problem. You only get one. Pick one thing to spend that £1 million against. This is the thing from a patient experience perspective, in your experience, that moves the needle for patient dissatisfaction and or frustration and or whatever you call it.
Okay, I'm going to answer that question as a patient as opposed to a doctor.
That's fine. Uncontroversial. That is something.
I would personally like a system whereby I can just go online, click, boom, there's my appointment there, it's booked, clicked, it's done. That's it. I don't need to have some back and forth, 20 emails to figure out when I'm free, when is the consultant available, this, that, the other. I just want to see it on a screen, see what's available. I know in my head when I'm available. Click, booked, done. That's what I would pick. It's 25 emails back and forth when they offer you time X. You can't do that. Then it's 2 days later they reply. Then it's time Y. That I can't deal with.
So I'll put it in my own words. £1 million to stop the to and fro.
Correct.
That's the thing that
Yeah.
and that changes the game for you. Something shows up, press one button, done,
Yeah.
booked,
Yes.
ready to go.
Yes.
As a patient, where do you expect that to show up? Does it show up there's no shortage of paper posts floating around.
No, I want just a nice digital solution, a little app on my phone or whatever. Click, done. Into my diary, done.
One click, done. Interesting. The experience you describe of toing and froing, we do a lot of patient correspondence here, and we analyze every conversation without patient names. We just say, what is the text, what was being said? And so we have this distribution of what's actually happening inside the patient conversation, because a lot of the analysis that I think EMRs, EHRs do is around appointments and medical notes, etc. But all that back and forth, that's taking medical secretary, administrator time and inconvenience to the patient, what's actually being said. And what we find is about 30% of that conversation is to and fro. 30% of healthcare conversations are to and fro. How about this time? Not that time. Oh no, they can't see that time. Oh, we need to reschedule because they're out sick now. Oh, actually, I got that wrong. Toing and froing, and the time lag on that to and fro is the killer. It's the killer. And you're nodding your head, so please go. As a patient now, go ahead. That drives you off the wall.
I have to say, I find it very frustrating. If you're the person who doesn't have much else to do and you're quite happy to wait for days for people to respond to you, fine. But people who are busy, just when the thing is there in your mind at the time, I just want the process to be completed and done in that instant, in that moment. And that to and fro back on, as you describe it, extremely frustrating.
Right now it's 2026. You can buy specialty almond milk, holiday shoes, and a plane ticket to Bali in about 3 minutes with 3 clicks online. But you can't get a healthcare appointment booked without 35 emails across the course of 5 days. It's 2026. When do you think, it's hard, you're not a fortune teller, but when do you think, for about the industry, when do you think that reality of click, boom, done, booked, no to and fro, no back and forth, when does that make its way to mainstream? When does that become the reality for people?
I think we have to, take a step back and understand why do we have this to and fro and this back and forth. And I think that it's important to say that, yes, you can buy a plane ticket to Bali because Bali is where you want to go, for example. But as we established, as we were discussing earlier, if you think you need a neurologist, but actually need a neurosurgeon, you think you need a neurosurgeon, but actually you need a neurologist, you don't want to go and book an appointment with the wrong person and see the wrong person for the problem, and you end up wasting time, money, etc. And that just pushes the waste further down the line. So I think ultimately, I don't know if I can put a date, but I think once there are systems in place whereby, because fundamentally what you need is information from the general practitioner who is acting as the filter, the person is going to make it much more likely that the patient is going to see the right person for the problem that they have. So you have the patient referral, having seen or discussed with an appropriate medical practitioner. Once you have a system that can then extract that information, and I think the technology to do this is here, okay, then you can then use that rather than me sitting there to triage or some human person doing it to then have an admin person book it. That process is automated, and then automatically you get, yes, your appointment is booked here in neurology, not neurosurgery, because that's not what you need, and that streamlines that process for the patient. So once on that side of you've got a clear direction of increasing the probability the patient is going to be channeled appropriately, I think that automation and few clicks and dependent on people like yourselves making these products, I think that will come maybe in the next 3 years. It does require a little bit of cultural change, I think, as well on the part of medics, which probably might slow that down a little bit. So the technology, I think, will arrive, I think, well ahead of significant adoption, perhaps, for a variety of reasons. But I think that's what effectively is what you need in order to be able to deliver that.
So it's interesting that I want to pick on the last thing you said. So there's, I think if you look across sectors, there are fast moving sectors and slow moving sectors. Fast moving sectors, e-commerce, consumer electronics, things where technology brings the convenience and price down. So 10 years ago, if you wanted to buy a flat screen TV, it cost X and you had to wait Y because there was a backlog. Today, you want to buy a flat screen TV, it costs a tenth of the price and you can pick one up at 11 p.m. from the corner store, right? It's completely changed because of technology. On the other side of that spectrum, housing, education, healthcare, these are things that would fall into maybe a slower moving category where technology has not yet created that unlock in price. The cost of education is going up, despite the fact that in theory, the cost of producing education should be going down because it should be more efficient and so forth. In theory, same could be said of healthcare. The cost of delivering healthcare should, in theory, be going down because technology should make things more efficient. And oftentimes the cost of providing healthcare is going up for unknown reasons. So it's interesting to hear you say that there's this maybe cultural change piece. And it'd be interesting to understand from you as someone who you wear the hat of a healthcare provider, a physician, but you're also in health tech. You have a foot in health tech. So you see people who are trying to move faster, and perhaps you experience in your common room people who are perhaps a bit more skeptical or slower to change or less interested or whatever the reason may be. So I'm curious, as someone who probably can and has stood on both sides of the bridge, what's missing? Where's the disconnect on a cultural level between, hey, we can do these things better, faster, more efficiently, and hold on a minute, let's just go a bit slower? What's the reservation? Why is there that disconnect?
I don't know if I would call it a disconnect. I think that with any new technology, you will have people who will adopt it quickly and you'll have people who will adopt it more slowly. That I think is normally distributed in the population. I think for most things, there will be people who didn't want a mobile phone because they thought they had brain cancer or didn't want a microwave, for example. People have different perspectives, and I think you will have a proportion who are very enthusiastic about something for some reason and don't have the reservations that some people have. Whereas it doesn't mean that the reservations that people have are not valid. So I think it is good to be skeptical, and it's good to have these people who have cautious and a bit more conservative, particularly in medicine, where ultimately the costs of things not going right are extremely high, personally for the patient, professionally for whoever is looking after them. There is a culture of where patient safety is the first priority. You have baked into your DNA from the time you're medical. Your job is to first do no harm. And that applies both to whatever medication you're going to give, whatever operation you're going to do, making sure you write the clinic letter in the right way with the right name and getting all of those details correct. So I think people being conservative and being cautious is simply part of the way in which medicine is practiced. And I think that is right. However, there is an element of habit. For example, I can give you for example, in medical school, you're taught to examine the patient always from the left. So as far as possible, I will move the couch. And the couch is the wrong way around. Yeah, if I could, but it throws you simply because you've literally habitually always done it like that.
Why do you do that?
No
Generally
idea.
from the left.
I don't know, maybe because if you're right-handed, it's just easier to have this hand as opposed to have that one closer to the patient. This hand's more free. I have no idea. But you always examine the patient from the left. So there's a routine. So like if you go to see a doctor who's doing a medical examination on you, they're not randomly pulling the order of what they're doing out of their head and making it up at the time. They have done that. I think even when I'm 99 years old and I can barely remember anything, I will remember how to do a neurology examination simply because I've done it exactly the same way over and over and over and over millions of times. So there is that element of it. People have, and that sort of habitual practice not only carries through in terms of the way in which you conduct your consultation or examine your patients, but the way in which you communicate. I've got friends, for example, who spend hours on their clinic letters and correcting their clinic letters. Some people spend far less. So somebody is very particular about how their communications are worded, for example, is not going to necessarily be the most enthusiastic person about adopting ambient voice technology because I'm like, well, no, I wouldn't say it exactly like that. Where somebody who is not as, not meticulous, because that's not, I don't think it's not the right word, but that isn't something that they feel is as important or part of their identity as a clinician, is therefore more likely to adopt a technology faster. So I think that what you fundamentally need to have, if you want to drive the change that I think that we do need to see to make things more efficient in certain ways, is that what you need optimally is to have that group of people who are interested and who are enthusiastic and who are engaged, who have been able to see the benefits, and then you use them to organically champion and spread the word amongst their colleagues, and they will bring people along with them. Because I don't think that there is any substitute really, particularly I think within clinical practice, of having the recommendation of a trusted colleague about something that they've found helpful or beneficial, or their patients have found very useful or a good approach to doing things.
Makes sense. I'm curious, you're building your private practice. And one of the things that we hear oftentimes from private clinics and clinicians is when they start, they come to realize that they are deeply expert in the provision of care. And then there's a whole lot of figuring out to do. Looking back at the beginning of your journey and navigating I'm going to use the word business, but the business side of private practice, what was that like for you? You're currently in private practice. In a future, you may choose to go off and practice privately elsewhere, maybe under a different brand, maybe under your own brand. I'm not sure if these are your future plans, but obviously as a private practitioner, there's always the possibility of building it from scratch, building it yourself. And I'm curious, as a practitioner, what are the reservations around the non-clinical parts of running a business? What sort of makes you feel like, I'm not sure about that,
Yeah.
as opposed to the areas that you may have more confidence in because you have experience doing those?
Right. I think that's a very good question, simply because it's a complete unknown in terms of setting yourself up to do more work when you're already doing lots of clinical work, usually in another setting in the NHS. Significant challenges are just a whole load of administrative things that you don't necessarily have any insight to until you actually start the ball rolling, getting yourself indemnified, getting practicing privileges, applying for that in a particular hospital, getting the whole administrative wrap around, billing, all of those things that you just have no clue about, because for the whole rest of your career prior to that, you just walked into hospital after induction and contracts and all of those bits signed up, all of those bits done. But you turn up to the clinic, you see your patients, you walk away and you leave, and that's it. So the challenges around doing that, not just the initial setup, but then managing the business side of it, I do think is actually for a lot of female clinicians quite off-putting, which is why I think you see a very different gender balance in private care in this country compared to what you would see in NHS within the same medical specialties, within the same geography.
Interesting. I wasn't aware of that. But okay, so your sense, your observation is that there are more male practitioners who are...
Oh, definitely, way more.
Not as, I don't know, is that specifically in neurology, or is that
across
the board?
Across the board. There are some specialties that are very heavily male anyway. So orthopedics, for example, let's take that as an example, is a very heavily male specialty. Whereas neurology is still more male, but a bit significantly more balanced. But you don't see that necessarily if you were to look for a private practitioner in neurology in this country. You would see that there are far more men doing private work than there are women.
And you think that your sense is that is because of the...
I think that's multiple factors, but I think at least one factor is the barrier to entry, the initial amount of effort and administrative work going into setting yourself up. And then there is also the whole other elements of it's not just me seeing the patient.
Interesting, I see. Okay, so it sounds like some of the headwinds against making that decision are actually nothing to do with healthcare, but instead all the other things, because actually you're fine with the healthcare parts. No problem at all to show up.
Very comfortable. You're very comfortable managing patients, managing them independently. You have networks of colleagues if you need to refer and things like that. So the medicine side of it is by far, delivering the care is by far the easiest part.
Fine. Okay. So it's the non-care parts of healthcare, which are sometimes the barrier to moving into private practice under your own brand, etc.
That is my view.
That is your view. Okay. Interesting. Yeah, makes sense. Okay, got it. So leaving that behind, one of the things that we see as a growing trend, possibly in more of the elective care than in what we might call the harder medicines, if you will, is this intersection of hospitality, healthcare. I think you see this a lot in dentistry. There are some dental clinics you walk into, you think you're walking into a 5-star restaurant or a hotel lobby, a spa, right? This is that intersection. Now, granted, when you're in those elective care practices, you are very much delivering a branded experience. And so there's a sort of expectation that might come with that, particularly at a certain price point. I'm curious, presumably go to a dentist.
Yes.
And so you have...
At least twice a year.
At least twice a year. Better than most, by the way. I'll tell you, we know firsthand better than most. So you've been to the dentist, you understand the hospitality experience that I think many dentists are trying to create or to curate, and that's now trickling into other parts of elective care as well. Do you see that as different to the work that you do or that you see in things like ortho and things like neurology? Is it a different school of thought, this idea that hospitality is a wrapper for care provision?
I would say that that's variable, and I think that it depends quite a lot on the setting. It depends on the clinician. It depends on their own perspectives on these matters. I think that one does have to draw a significant distinction between, say, cosmetic dentistry and somebody seeing an oncologist. These are two vastly different scenarios, even though they probably both sit under the umbrella of healthcare. They're both seeing medically qualified people. However, I would say that all of these elements, feeling like you're welcomed, feeling like you're looked after, feeling like somebody actually cares, there's lots of different ways to do that, but delivering that sensation or that emotional feeling that somebody actually cares about you as a patient, I think is important. And I think that clinics, healthcare providers need to seek to do that in the best way possible with whatever resources they have.
It sounds like a big part of delivering high quality care, irrespective of cosmetic dentistry or oncology, is I, as a patient, feel like there's a relationship and that someone on the other side, or multiple people, an administrator and or a practitioner and or know me, care about me, are checking in on me, are there for when I need something. That sounds like customer service. If you look in airlines, as an example, I love airlines as a business model in terms of comparing to healthcare. You have to move a lot of people around. Healthcare is a lot of moving people around, getting people to certain places on time. Things need to happen a certain way. I wouldn't say that airlines do a particularly good job with customer service. There's a lot to be desired.
Where are you going with this?
Yeah,
Okay.
I think there's a lot to be desired in airline customer service, but I think the logistics of air travel are not that dissimilar from the logistics of healthcare provision. You need things to run on time. People need to get between things. When one person's late, everybody's late, and it has this sort of chain reaction. But the idea of customer service, I think, is something that airlines or travel businesses or service-based businesses in general, which ultimately is what healthcare is, invest an incredible amount of money in customer service because they see customer service as a way to improve brand, improve reputation, improve customer experience, improve revenue, et cetera, et cetera. There's no shortage of good things that come out of great customer service. And it sounds, be that in elective dentistry, cosmetic dentistry, or oncology, customer service is in many ways part of the care experience. And I guess I'm wondering, as a non-practitioner from the outside, how often is the customer service conversation or the patient service conversation, which I think is quite different than patient experience in that it's specifically around troubleshooting, triaging, handling the questions. How often is on the strategic board agenda, here are the top 3 things we need to work on this quarter, here are the top 5 priorities for the trust, for the organization. How often do you see customer service as a top 1 or 2 priority?
I think that is like a difficult question to answer, I think, Farrah, because I think obviously the most important part of the customer service, as you're using your term, in patient care is making sure that the patient gets the right care
100%.
at the right time. So the medicine in and of itself is important, and ensuring that we do that well is the number 1 priority. Like when you get on BA, the CEO safety is our number 1 priority. Yes, the plane, all I want is the plane to go up and land. I'm not too bothered about the size of the seats or any of those things. All I want is smooth flight, minimal turbulence, and I want to arrive still alive. That's, I don't like flying. That's my
Basic.
priority.
That's
I
it.
just went ahead and say, your safety is our number one priority. That line, I love it. So I'm like, that is an. But you're quite right. They cancel your flight. I had children wailing in the airport. You just get some text that though it's nothing. They put you in some hotel where the food is like not great. And all of these things, and they do matter. They would impact decision making as a consumer where you have a choice. I fly to Trinidad fairly often. I don't have another choice unless I want to go a roundabout route. But if I want to fly direct to Trinidad, I have no choice. I have one provider. I've got to fly British Airways. So they can treat me badly. They can treat me well. I will be flying British Airways to get to Port of Spain. So they do have a monopoly on various Caribbean routes. But in a situation where somebody has a choice, where a customer has a choice, and obviously patient experience is an extremely important part, in terms of the elements that you were talking about, that I would say are not necessarily core to what you deliver, but they are very important, or sometimes even more important, or as important to the patient experience as the things that you feel are your priority as a healthcare provider, which is the healthcare in and of itself.
It's interesting. One of the other metaphors that we often kick around is a restaurant. And you go to a restaurant and you go there to eat. And so if I draw a very overly simplified comparison between healthcare and a restaurant, when you're providing healthcare or you're serving food, you go there for the food. You don't want to walk out with food poisoning. Bad. So there's like a baseline on the pyramid of needs and expectations around going to a restaurant, which is give me the food that I asked for and don't make me sick. And in a clinical setting, I think it's the same thing.
Yes.
Your safety is the number one, number one concern. In a clinical setting, you came with a healthcare problem. We need to address the problem correctly. We need to send you off happy with the outcome to the best of our ability, etc. There's a clinical responsibility that goes with not giving people salmonella when they come for sushi, right? I think it's just a baseline. But you can very well walk into two restaurants, both of them serving
the same
chicken,
have a very different experience.
And have a very different experience. And your point, where do you go back? And it's absolutely if the chicken are indistinguishable, and I'm not saying that all healthcare is indistinguishable, but a very high quality practitioner here and a very high quality practitioner here, in some ways it's just about chemistry, or it's just about fit, or it's just about, it can be indistinguishable. Obviously, not everyone can do the healthcare provision in the similar way that not everyone can be a Michelin star chef. But when you reach a certain level of care provision, from a business perspective, that do I go back to A, or do I go to B, or do I go to C? This is often a result of the non-food parts of the restaurant.
Completely agree. And that's why I would say the administrative side of medicine is extremely important, as important as what we are doing in terms of the delivery at the point of care. I'll give you an example. If you see somebody about their headache, let's make it nice and easy, a migraine, and you prescribe a medication, the patient's gone home and they've tried the medication, it's not worked, or they've had a rash or something as a result of it, and they send an email in to say, I've had this problem on this drug. What should I do? If that email doesn't reach me for 2-3 weeks for whatever reason, and it's nothing to do with the individual provider, but that patient has now had a very bad experience because that information does not reach the person that it needed to reach in order to make a decision to be able to help them with the problem that they have. So the clinician and the healthcare and the point of care is at the core, but there are all of these other machines operating around that ensure that you can do your job to the best of your ability, and therefore can deliver care that patients are likely to deem of a good standard.
It's interesting. We had someone else that we spoke with, and they had an experience with a pediatrician. It was a maxillofacial pediatrician. So specifically, of course, I didn't know, but you of course do know. And they were describing the experience of going there, said it was wonderfully organized, really high quality. The booking coordinator was very effective, diligent, quick to respond, all the right stuff. They went in, the specialist said, I noticed that there's some deep bruising because the child is 2. We're not going to do anything more, but if it persists and doesn't resolve in the course of the next 3, 4, or 5 months, then... Now, the thing that was so interesting about the story was it seemed like the clinical care at that moment was great. And there was the casual, if it's still an issue in a few months, let us know.
In touch.
3 months pass, 4 months pass, 5 months pass. Who owns that problem? Who owns where does that responsibility live? Is it the patient? they need to get back in touch? Is it the provider? Obviously, if it resolved itself, no problem, but nobody actually knows. And life is busy. You have a kid, 2 years old. You're lucky if you can find your shoes in the morning. We both know. It's a different reality. So where does that responsibility sit? Is it the patient who should be saying, ooh, this is still not resolved, I need to take an action? Or is it the administrator who needs to say, hold on, we need to check in on this person? Is it how does that get
done? So I suppose my answer to that would be, it depends on the conversation that was had with the patient at the time, what their expectations are, what is delivered. If you, as the clinician, making this, either you have to have one of basically adding 3 scenarios. If you think that there is a probability that there is still going to be a problem that you need to address after a time interval, and you want to be as sure as possible that the patient is going to return, or that you will know that you have at least given them the opportunity to return, then you would schedule a follow-up appointment. If it is the case that you anticipate that the problem is going to resolve itself, and therefore it's very unlikely that they're going to, you don't want to book up an appointment unnecessarily for somebody who doesn't need it. And in which case, very often, I, for example, give a patient option. I could leave it to you to get in touch if you want, and you can do it that way, provided that you have systems that are sufficiently robust that should somebody make that contact, it's likely to reach the threshold, it'll actually come through to you as is. Then there can be a scenario where you think there might be a problem, or there is the low probability situation where you're not expecting a problem, but one has arisen, and the patient may not necessarily recognize it as a problem, or they may have the problem. If there was a problem, somebody would have done something else, or less agency necessarily on their part. And I guess those are a cohort of people that I think you would have to be concerned about, and at least be certain that you have systems in place that if they were to try to get back in touch with you again, that they could do so in a manner that was efficient and expedient.